Hello, good afternoon. Welcome everybody to this webinar on alcohol assertive outreach treatment. I see the numbers are still increasing of people joining, so if we give it maybe a minute before we start, and then I'll introduce what we're going to discuss this afternoon. Okay, I think we'll make a start. So welcome everybody. This is a webinar on the implementation and evaluation of alcohol assertive outreach treatment. And we're going to talk about the work of the NIHR Mental Health Implementation Network. I'm one of the two project leads. My name's Colin Drummond. I'm Emeritus Professor of Addiction Psychiatry at King's College London. And my co-project lead is Professor Amy O'Donnell from Newcastle University. And she's going to be speaking to you shortly. So this is the culmination of 6 years of work, and it's exciting to share our experience and findings about implementing alcohol assertive outreach treatment in 3 regions of England. And we very much hope there will be some messages to take home which will encourage you to further spread and adopt this approach across England and beyond. Next slide, please. So just a little bit of housekeeping. All the delegates who are attending will be muted throughout the event, but please use the question and answer function for questions. I'll show you where that is in a moment. You can vote on which ones you want to be prioritized by adding a thumbs up button next to the questions you're interested in. The event is being recorded, and if you need to, please enable the captions. So there's a button at the bottom for closed captions. For any technical issues or support needed during the webinar, if you could contact Michelle Harris-Tafiri, or you can use the chat function. Next slide, please. So if you'd like to share the event on social media, please use the following blue sky tags. So there's ARC South London, ARC Greater Manchester, and Yorkshire and Humber. You can see the, the hashtags there. And to engage with others in the webinar, please use the chat window for any general points or technical questions. The team will be monitoring that as we go along. But if you switch to the Q&A window at the bottom, you can see the button highlighted there. You can put any questions for the speakers in there. Next slide, please. So to ensure that this is an inclusive environment where open discussions can take place, please avoid acronyms where possible. I'll try to do the same. Be respectful and allow room for constructive challenge. And after the event, share the information you receive, but not the identity of who said it without their agreement. Next one. So the agenda, we have 2 sessions. The first session has 3 presentations followed by a question and answer session. Then there'll be a short break. And then the next slide is the second part where there'll be 4 presentations followed by a question and answer session. We aim to finish by 5 o'clock. Next one, please. So I'm just going to give you a brief introduction to the NIHR Mental Health Implementation Network, about what it is and what we're trying to do. So next slide, please. So the MHIN, which is short for Mental Health Implementation Network, was commissioned by NIHR in 2020. And you can see in the slide here, these are all the different ARC regions, and quite a few of them have been involved in this project. The project's been jointly led by ARC South London, where I work, and ARC East of England. So the problems being addressed by this network are the huge care gap in mental health, the slow translation from evidence into practice, uneven implementation, and the fact that there are underserved populations and conditions. Next slide, please. So the overall aim of MHIN was to catalyse and evaluate implementation of high-impact, evidence-based mental health interventions super-regionally or nationally. So in the early stage of the project, we brought together a multidisciplinary group of key stakeholders, so clinicians, scientists, patient representatives, policymakers, and others to form the network. And the first piece of work was to identify evidence-based solutions that meet system and patient needs and are ready for implementation in the short term. There were quite a few processes. Some of you on the call may have taken part in those prioritization exercises that we did. Once we'd identified the interventions to implement, we then worked with stakeholders to support implementation in some selected areas, and we're going to tell you about one of the projects this afternoon. And then the stage we're at now is developing proposals for further research, funding to support implementation, and also disseminating the findings from what we've done in the first part. Next one, please. Next. Keep clicking until they're all. So it was commissioned in 2020. 2021, we did scoping and prioritization. The ARC sites were appointed to take part in the implementation. We're now towards the end of implementation and evaluation, and we're looking at sustainability and impact, and you're going to hear a fair bit about that today. Next one. So there were 3 projects selected to take part, one on improving access to mental health for minority ethnic communities, one on children and young people, and if you click, I think it'll highlight the one we're talking about today. So we're looking at integrated care protocols for substance use, mental health, and physical health problems. And the 2 regions that took part were Yorkshire and Humber and Greater Manchester. I'm going to introduce speakers from those 2 regions shortly. Next slide, please. So before we get to the implementation, just a bit of background about alcohol assertive outreach treatment. And what we were aiming to do here was to implement high quality alcohol assertive outreach treatment. Next slide, please. So what is assertive outreach treatment? Well, it's a model of care where health professionals support service users at home or in their neighbourhood rather than asking them to come to a clinic or hospital. And it's an established model of care in severe mental illness with quite a strong evidence base, but it hadn't really until recently been applied to addictions, or in this case, alcohol dependence. Next, please. So it's provided by a multidisciplinary team, which includes outreach practitioners, psychiatrists, psychologists, specialist nurses, occupational therapists, and has links to housing support workers and addiction and adult mental health services and social services in the community. And the team works proactively in developing and maintaining lasting supportive therapeutic relationships with service users and their carers. Next, please. So where has it been implemented before? Well, the early ones to implement were in Salford, which we're going to hear about from Dr. Carr shortly. And also we did an initial pilot study in South London, which was published in 2017. But we also did a survey, a national survey, which found that there were 19 assertive outreach services across England of whom 6 were high fidelity or high quality services. So the majority are not as intensive as what we're going to describe in this webinar. So what we did in South London, we did a trial of alcohol assertive outreach. We worked with patients and clinicians to adapt an assertive outreach treatment model used in severe mental illness. We developed a training manual and a training program for practitioners. Alcohol assertive outreach treatment is much more intensive and prolonged than standard alcohol care. We set up an alcohol assertive outreach clinical team for Lambeth and Southwark. We created partnerships with hospital and community teams in those boroughs. We then identified alcohol-related frequent hospital attender patients through hospital e-health records and recruited 174 patients into a randomized trial of alcohol assertive outreach versus care as usual. So there were 87 per treatment group. And that 174 was just over half of all the frequent attender patients in Lambeth and Southwark based on clinical records. Next. So this work I'm going to present now, it was done by Amy Wolstenholme, who's joining us on the call. She evaluated the impact of alcohol assertive outreach, both on admissions and on costs. So you can see the alcohol assertive outreach treatment is in blue and care as usual in orange. And the baseline refers to the 6 months before people received assertive outreach or care as usual. 6 months refers to the 6 months after they were recruited up to the 6 month point. And then 12 months refers to the period between 6 and 12 months. And what you can see is there is a little bit of a reduction in mean number of hospital admissions in the care as usual group. It's reduced by 30%, but there's a 61% reduction in the alcohol assertive outreach group, which means that the alcohol assertive outreach group had 42% less admissions than care as usual at 12 months. Next slide, please. Next slide, please. Thank you. And we also looked at the number of alcohol admissions overall to King's College Hospital, which was one of our main recruiting sites for patients. And you can see that after implementation of the service, there was a 23% reduction in overall alcohol admissions. And that's because we targeted their most frequent attenders to try and help them to find better ways of managing their health in the community. Patients reported increased self-reported quality of life, and they reported 100% satisfaction with the service. Next slide, please. So in terms of economics, what Amy found was a saving of £10,470 per patient per year compared to care as usual. The cost of the assertive outreach treatment was £3,100 per patient, and that equates to a return on investment of £3.34 for every pound spent. And if that was applied to all the frequent attender patients in Lambeth and Southwark, which is 324, that equates to a net saving of 3.4 million per year. And on the right, we have a scatter plot, which shows you basically cost on the vertical axis, so that the further down you go, the more you're saving in costs, and quality of life is going horizontal, so the more you are to the right, the better the quality of life. So you can see most of the cluster is in that southeast quadrant, which means that the intervention is highly cost effective. Next, please. So what makes an effective assertive outreach treatment service? Well, we published a study in 2017 which identified the key characteristics of a high fidelity assertive outreach service. You have to have a small caseload of between 10 and 20 patients per practitioner, which is much smaller than typical addiction services who have between 50 and 100 patients per practitioner. So that allows them to do much more intensive work with individual patients. You have to have a multidisciplinary team, regular contact with the patient and the practitioner at least once a week, with the majority of contacts being outside the clinical setting, usually in the person's own home or local neighbourhood. And there's a focus on both health and social care needs, with care extended up to 12 months. Click again, please. And that's been published in our national survey paper. Next slide, please. So our research questions, if you click again, Flavia. So can high quality assertive outreach be implemented in the relevant new settings? Does implementation of high quality assertive outreach result in positive outcomes for patients and providers? Next one. What factors shape more or less successful implementation of assertive outreach? And finally, how can assertive outreach be sustained and scaled up over time? So those are the things that we're going to turn our attention to now. So next, I'm going to introduce, I think Tom Phillips is going to present first, followed by Tyler Mills. So handing over to Tom now.
Thank you very much, Colin, and it's a privilege to tell you about our project at Hull, which we've named as the Collaborative Alcohol Care in Hull project, known as COACH, that is looking at the implementation of high quality assertive care in our local authority area. I'm going to speak for 10 minutes and followed by Tyler, who'll tell you a bit more around the qualitative aspects of our research project and evaluation. But I would like to acknowledge individuals on the slide, in identifying Philippa Case, Laura Herman, and Judith Cohen as members of our research evaluation team. I'd also like to acknowledge Renew in Hull, who are part of Change, Grow, Live, who actually were the recruited service provider for the assertive outreach team in Hull, funded by Hull City Council, and supported by the local NHS trusts in terms of developing care pathways for complex individuals. Next slide, please. So our aim of our research was, can the City of Hull develop and implement a new alcohol assertive outreach team that meets the threshold for high quality as described by Colin in the earlier slides and tested by their team? The idea was to identify a clinical audit and qualitative research program that wasn't a randomized controlled trial. It was pragmatic in its nature, but it would assess the feasibility of developing a new model on the patch in Hull and give us an indication of to what extent we can have fidelity to the high quality model here in Hull across the city. So we worked with the Acute Hospital Trust and the local service provision to develop a new service. Next slide, please. So the background is that Hull City Council has a mature strategic partnership for drugs and alcohol. It's led by the public health team, as in many other areas, but particularly we have a significant integration of all service provision. And we identified in 2018 the need for potential alcohol assertive outreach, which actually was paused as a sort of strategic plan because of the COVID pandemic. However, the emergence of the MHIM project allowed us to build some momentum around developing the project, and funding was allocated initially for a 2-year pilot period starting in 2023, with ourselves at the University of Hull providing the evaluation. Success has been born out of this project, and now the service has sustained funding moving forward. But it's on the background of having significant high rates of community prevalence for alcohol dependence, which is identified and mimicked in the hospital. There's significant social determinants that increase the impact of harms across our area. And perhaps a little bit unusually, we have very high rates of 3 or more admissions for individuals with alcohol-related problems in the hospital, which in some ways reflects our community prevalence. Our initial target was to recruit potentially 60 to 100 patients through Renew services, with a new team being developed from practitioners, a lead nurse, and a manager and psychiatrist providing sessional input. And our aim was to target, similarly as described by the King's Service, repeat attendances and admissions to hospital for alcohol dependence for individuals who are not currently engaged in any other service provision. So if we go to the next slide, we were able to form 2 parts of our research and evaluation. First, the clinical audit, which I'm going to talk about, where we used sources of data, such as clinical case records, and we used items on the treatment outcome profile, which is routinely collected information for all drug and alcohol services nationally. We thought that was a much more pragmatic approach to our evaluation that could potentially be rolled out. Our additional sources of data for our clinical audit were hospital records for ED and admissions. We were able to recruit a cohort of 40 individuals out of the 60 recruited into the service to do a evaluation at baseline, 3 months and 6 months. And I'm going to just give you some headline data before Tyler talks about the interviews that were conducted on service users and other groups. Next slide, please. So one of our primary outcomes was looking at alcohol consumption. And we've measured the alcohol consumption in terms of the alcohol used in the 28 days prior to baseline coming into the service, and at the 28 days prior to the 6-month cutoff period. You will see on the plot to the right, there are 2 blue boxes, and they refer to the units of alcohol consumed by individuals at the beginning of the service, which identifies approximately around 30 units of alcohol consumed on average on days drinking. Those who continued to drink at 6 months actually reduced their consumption when drinking and reduced it to around 20 units. So there was a 30% drop in alcohol consumption at 6 months. If we look at the green boxes to the right, these are days of drinking over that same period. So at baseline, people were roughly drinking around 20 out of 28 days in the previous at baseline, and that sustained level of drinking was maintained. So there was a 30% reduction in those who continued to drink. So recognizing that assertive outreach may have positive outcomes on people's drinking status if they continue to drink. But notably, we found that 1/3 of the individuals actually abstained from alcohol over the period, and we had increasing abstinence rates over that period. So we suggest that our model of assertive outreach, which reflects the King's high fidelity model, has an impact on both supporting complex individuals becoming alcohol-free, but also reducing the drinking in the remaining cohort. Next slide, please. We also looked at measures of quality of life at 3 and 6 months and baseline across the period for same groups. And quality of life is measured on the treatment outcome profile, the top form, by a metric that's scored on 0 to 20. And the greater the score, the greater quality of life is rated by the individual. And here we have a grouping of 3 measures: physical quality of life, psychological quality of life, and overall quality of life over the time points. And what we were able to identify was that psychological health and overall quality of life were improved significantly when we tested it statistically at 3 months, and that improvement was again sustained at 6 months. However, the same was not true for physical health quality of life, and probably reflects the severity of some of the physical coexisting conditions that individuals had as they came into the project from out of Whole Wall Infirmary. So again, positive outcomes on quality of life were identified across the cohort. Next slide, please. We then move our attention to hospitalizations in the form of emergency department attendances and hospital admissions. These graphs show the blue at baseline, the reported ED attendances 6 months prior to coming into the service and 6 months post-service attendance. And we can see that there's significant reductions in A&E attendances across the cohort, and also hospital admissions reduced by 50%. So we can see significant reductions in both those groups, which again reflects the work that Colin presented earlier. Next slide, please. We also look at hospital occupied bed days. And whilst there isn't a significant reduction, there's a significant spread across the cohort, we can see that there is a marked decline in hospital occupied bed days. We've actually costed up this reduction and to try and understand the reductions and the cost savings that could take place in our area. And we've identified that there is a cost reduction of approximately £8,000 per individual at 12 months. So again, reflects similar trends to that described by Colin and his team. I think that's, if we go to the next slide, it should be an introduction of Dr. Tyler Mills, my colleague here at Hull.
Hi, thanks, Tom. So I'm going to be talking about the qualitative side of the evaluation, and we used a theoretical framework called Proctor's taxonomy of implementation outcomes, and we wanted to explore the acceptability, feasibility, and impact of implementing AAOT in Hull. We also wanted to look at fidelity to the high quality model of AAOT, which Colin described earlier. Next slide, please. So we spoke to 8 staff and stakeholders through interviews and focus groups, and we also spoke to 9 service users. And we used framework analysis to analyze the data, and this emerged 4 different themes with different sub-themes for staff and stakeholders. So we're not going to discuss all of the themes and sub-themes in depth today. I'm just going to talk about some of the emergent findings from each one, which we think are significant. Next slide, please. So the first finding that I want to discuss is that first impressions count. So the service users reported that there was some initial confusion between the difference of AAOT versus traditional alcohol support services. However, this confusion was rectified when they got to meet their key worker, who was able to explain AAOT in a lot more detail. And so we found that it was very useful to have the AAOT practitioners as a sort of AAOT champion, who were able to discuss what the service was and why they had been referred into it. Additionally, it was very beneficial for the key workers to approach potential service users in hospital and to present the service to them at bedside. This was then followed up 48 hours after discharge in what we term a warm handover. However, not all of the key workers had access to the hospital, and their ability to access the wards to talk to service users changed, as the referral processes also changed during the implementation. When we talked to the service users, they described some of the barriers to understanding what the service was and why they might have been offered it. These included the effects of medication, illness, and alcohol withdrawal. There was also alcohol-related cognitive impairments, distress, and some people had negative experiences with being in alcohol support. So this was really useful to understanding why there might have been some misunderstandings around what the service was. Next slide, please. The next finding I want to talk about was the importance of the relationship between service user and key worker. And I think it was really best described by this lady who was a service user. And she said that she wanted a bottle, you know, alcohol, alcohol, alcohol. But it was her perseverance in a kind way. She got me out of bed, she got me downstairs, and she said, right, I'm going to make you a cup of tea. So she made me a cup of tea, and that was the start of it. That was the very beginnings of someone caring enough to get me out of bed. So we begin to see here how the relationship between service user and key worker is integral for delivering AAOT and providing a positive experience of care. Next slide, please. The next finding was that service users experienced a very high amount of stigma when they were attempting to engage with traditional services. And stakeholders described how there was a lack of other suitable services in the area for this population, and they thought that this had a negative impact on referrals. A lot of the service users and the AAOT key workers reported that the stigma was mitigated through something that we call assertive advocacy. And assertive advocacy emerged as a key feature of a positive experience of care. Next slide, please. So what is assertive advocacy? Usually when we're discussing assertiveness and AAOT, it's in terms of engaging service users. But we describe assertive advocacy as the key workers repeatedly and persistently advocating for better care for their service users with other services who are involved in that care. The service users were often very socially isolated and marginalized, and we found that the key AAOT key worker was sometimes their only advocate. And this advocacy was very necessary, particularly when service users had health and social care needs, which were being unmet by other agencies. So training in advocacy for the AOT key workers is highly recommended in order to strengthen existing skills and enable them to preserve professional relationships while also advocating for better care. And we found that this could be a factor which facilitates sustainability of AOT. Next slide, please. So one of the outcomes that we wanted to look at was the impact of AOT. And we spoke to a nested sample of 9 service users out of the cohort of 40. And 8 of these 9 reported changes to their alcohol use, which they thought was a consequence of the support they received in AOT. They also reported that they were managing to attend healthcare appointments a lot easier, and they felt more able to manage long-term conditions such as diabetes and liver problems and other chronic conditions that they had. One of the most impactful things that service users reported was improvements to their well-being and their quality of life. This was particularly felt as a result of the practical support that was offered to them. So this was help with benefits, help with attending their appointments. And it was through these small steps that they began to cultivate a sense of hope and a sense of optimism for the future. Next slide, please. So as we spoke about earlier, we wanted to look at fidelity to the high quality model of AAOT, which are these 6 factors in the middle, which Colin highlighted earlier. So if you look on the left side of the screen, the green tick boxes indicate where we were able to confirm that fidelity to the high quality model of AOT was being met for that specific factor. The orange boxes show that these were positively endorsed by the people who we spoke to, but we weren't able to confirm it through the interviews and the qualitative evaluation alone. For these aspects, we then looked at the case note review. So we reviewed a sample of 8 case notes for people who were in the AAOT program in the first 6 months. And we found that these were, again, being met with high fidelity to AAOT. So when they were having input from MDT, these were always attended by at least 2 practitioners, 1 specialist nurse, and 1 psychiatrist. We also wanted to investigate how much contact was happening at home and in the community. And we found that there was 90% of the contacts in the case notes were happening at the patient's home, and 5% were happening in the community, which was stuff like going to cafes and other things like that. And we think that the very high rate of home appointments is another factor which might indicate the severity of the chronic illnesses and the physical comorbidities in this sample. Next slide, please. So we looked at the barriers and facilitators, specifically from an implementation perspective. And we found that the resources, such as funding and transport, so the ability to transport patients in cars, that was reported by stakeholders and by practitioners as a barrier. As I mentioned earlier, the NHS contracts in access to the hospital wards to speak to potential service users. This was also initially a barrier while there were unstable NHS contracts. Staff support and well-being was at times seen as a barrier. This was because of the risk of vicarious trauma to the practitioners. So vicarious trauma is trauma as a result of being exposed to the trauma of other people. And we found that staff support was really crucial because of the risk of vicarious trauma. A final barrier was reconciling tensions between the ethos of AAOT, which involves flexibility, empowerment, and autonomy, and reconciling this within standard service provision, which doesn't always help people to do those sorts of things. There were also some facilitators which ameliorated the problems which were experienced during implementation. One of these was a high level of research involvement and partnership working, which continued throughout the implementation. And this was further helped by the implementation meetings, which were highly attended by service providers, staff, practitioners, stakeholders, and researchers. A final facilitator was reported as a community of practice. This was attended by the key workers and other members of staff, and they reported that this was very good for receiving support and sharing knowledge. Next slide, please. I'm going to hand over to Tom now for the conclusions.
Thank you, Tyler. And so in conclusion, we have identified that high fidelity to high quality assertive outreach teams in a new area such as Hull can be facilitated, particularly by the collaborative approach of the research team and the MDT. There's been resoundingly positive experience for all parties, including the local authority, and there's a significant belief in the model that has actually sustained funding for the longer term. We've identified improvements in alcohol use, quality of life, and reductions in hospital service use, which we've estimated to have saved in 6 months over £130,000 across 34 service users, which we estimate could be equivalent to £8,000 per individual. Our recommendations are to consider a warm handover from hospital to assertive team, which involves integrating the pathway in the hospital and follow up within 48 hours. Assertive advocacy is an essential facet of the service and skill base for staff, and a trauma-informed approach. All these elements are going to be discussed more broadly in our toolkit that we'll be publishing as a consequence of this work. Thank you.
Thanks to Tom and Tyler. I'd like to introduce now Dr. Stephen Carr, who is a consultant psychiatrist and senior lecturer at Greater Manchester Mental Health Foundation Trust and Manchester University. And Stephen Carr was the lead in the Greater Manchester part of this study. Stephen.
Thank you very much, Colin. Nice to meet you all. Yes, so I'm going to talk through our mixed methods evaluation of the implementation of the alcohol assertive outreach treatment model in Greater Manchester. And you'll find that we touch upon a lot of similar themes actually to Tom, Tyler, and Colin. Next slide, please. So before I go on to tell you about our research findings, I just wanted to acknowledge that this has been a huge team effort. If I start over on the left, Nicholas was responsible for recruiting, coding, analysing the vast majority of the data with Laura. So without him and Laura, this would have been a very different project. We also got incredible help from Karina at the University of Manchester and Colin and the team at King's College London, Amy O'Donnell too at Newcastle, obviously Tom and his team in Hull. We had loads of help from our clinical team too, including Dr. Tracy Mighton, Julie Curry, who leads the HISMIT team, which we're going to be talking about. That's an alcohol assertive outreach team, as well as Anthony from HISMIT, Christine from HISMIT. Stan should be on here as well. Neville, and then Stephen Blood, who's our PPI lead, who's going to talk about the patient's experience. Because we used retrospective data from 3 different NHS trusts, we relied hugely on our business intelligence teams across those 3 organisations, so Greater Manchester Mental Health Foundation Trust, Bolton Royal Hospital and Salford Royal Hospital. I think one of the strengths of this study being in the NHS was that we were able to do that so effectively in a fairly short amount of time and gather a huge amount of data. So I thank everyone for their help with that. Next slide, please. So why should we be interested? Well, in the Northwest, the rates of alcohol dependence are amongst the highest in the country. If you look at the graph here, you can see actually on the left, we're second only to the Northeast in terms of rates of alcohol dependence. If you click again, please. And locally, looking at Bolton and Salford, which are our 2 local sites, you can see that there are high levels of alcohol-related deaths. There are reasonable numbers in treatment. There are high levels of alcohol-specific alcohol admissions as well in both Bolton and Salford. And there's a group of people, as Colin alluded to, who have alcohol dependence and who present to health services in crisis who disproportionately account for those unplanned admissions. And it's this alcohol assertive outreach team model that hopes to tackle that, really, to help people engage in community care without needing to be in crisis. So next slide. So in case you didn't know where Manchester was, there's a guide down there, the north. This was presented in Lisbon, which is why we've got that map there. So our study is called VALOR, which is the value of outreach. And as I said, it was within an NHS-led collaborative. So within Bury, Bolton, Salford and Trafford, Greater Manchester Mental Health Foundation Trust lead the Achieve collaboration, which then is responsible for subcontracting to third sector organisations and acute trusts as well to run addiction services in those boroughs, including the AAOT teams. And so we were interested in looking at the AAOT team in Salford, Service 1, the HISMIT team, and Bolton, which is run by the Big Life Group. And you've heard a lot of mention of these different 6 criteria, and it's because we think it's quite important to explore how these criteria impact on implementation and potentially outcomes. And that's something that we've explored as part of this study. It's worth, I think, saying that Service 1, because we're going to talk about the differences between services a little bit, is the HISMIT team. That's one of the longest running alcohol assertive outreach teams in the country. And if you look on the right here, you can see, according to those 6 criteria, it ticks all the boxes. And they also have an interesting referral route, which is that anyone who presents to Salford Royal Hospital or is admitted to Salford Royal Hospital more than for 2 or more times in a month for an alcohol-related reason gets identified within the hospital system and then referred to the HISMIT team, who can then go and see the patient pretty rapidly. Service 2 is Big Life Group, who have a much broader referral criteria. So they will see referrals from GPs, community drug and alcohol teams, other local authority organisations, social services, and hospitals too. So they tend to have much bigger caseloads, although not at the rate that Colin was talking about. So they probably do breach this 10 to 20 criteria. But their goal, the goal of Big Life, is to transition people assertively from these difficult situations in the community where they're unable to access care to the community drug and alcohol teams. So a slightly different model. And this is why they tend to work with people for a shorter period of time, which is why they don't meet this last criteria, as you can see there on the bottom. However, Big Life do work with people over a prolonged period of time. They just tend to try to get people into the community drug and alcohol services first. If that doesn't work, they re-engage with them. So they do work with people over an extended period, but not in a single treatment episode. Okay, next slide, please. So we wanted to determine who's using the alcohol assertive outreach teams in Bolton and Salford. So look at their demographics and clinical characteristics. Obviously, we're beholden to the data that's on the clinical record because this was a retrospective study. we wanted to measure the effect of the model on patient experience, engagement, and healthcare utilisation. And we did that via our retrospective data collection, but also by our qualitative study, which I'll tell you about too. And we wanted to explore the implementation of AAOT and look at the sustainability of AAOT in Greater Manchester and the Northwest, and see how we could generalise that learning to the rest of the country, which is why we're talking to you today. Next slide. So, as I've alluded to, we had two methodologies or designs within our project. So we have our quantitative service evaluation, which was among the NHS trusts, approved as a service evaluation. Because we had data sharing agreements, we were able to collect a large amount of data, and we were able to do this 12-month mirror image analysis where we looked at the period 12 months before the AAOT intervention and 12 months after. And we did that over a period of January 2018 to March 2022. And we were interested in looking at whether there were changes in emergency department attendances, ward admissions, hospital bed nights, and contacts with the structured care team. So SATS basically is the community drug and alcohol team. And we used some fairly rudimentary statistical analysis to measure that change. And we combine both samples together, you get 1,800 patients. So good numbers. And then our qualitative research study, which was approved through the Research Ethics Committee and the HRA, was used as semi-structured interviews. So we recruited 66 people in total, including 18 service users, 20 members of staff from the AAOT teams, and the service users were either under AAOT at the time or had recently been in contact, and also 28 local and national stakeholders. And so that included commissioners within Greater Manchester, further afield, people involved in commissioning AAOT services in other areas, people involved in policy, to really try and get a broad overview of experiences of AAOT. So we did interviews with this group of people and developed topic guides, including with people with lived experience. And then we used a framework analysis, which is a type of thematic analysis based on two frameworks. So we used the Consolidated Framework for Implementation Research, or CIFR, and that helped us look at the barriers and facilitators of the implementation of AAOT. And we also used Proctor's taxonomy, which Tyler alluded to as well, to look at fidelity, sustainability, and adaptability of it as well. And yeah, we used deductive and inductive coding. Next slide. Thank you. So in terms of that characterization, that first aim, well, we found that 36% of the sample were female, 48 was the average age. The vast majority were white British, heterosexual, and there was a fair number of unemployed people and people who were long-term sick or disabled. But interestingly as well, there were a significant number of people who were employed, which is a bit of an unexpected finding. We're not going to talk about it today because it's a preliminary finding, but it seems like employment to some extent does predict outcome, in that people who are employed or recently employed tend to do better, which is, I think, an interesting thing to think about. Most people were in mainstream housing, but there was a tiny but significant amount of people who were homeless too. Some people had multiple disabilities, but often they had none. And one of the disadvantages of using routinely collected data, which I'll talk about in the limitations as well, is that unfortunately we haven't yet been able to get very good coding on mental health disorders, but that's something we need to look at. Okay, next slide, thanks. So these are the results of our quantitative service evaluation. And if we start with the graphs at the top, this is showing change in emergency department attendances. So at the top left, this is service 1. So our the highest fidelity team, although both teams are at least medium to high fidelity. And you can see here that there is a significant drop in A&E attendances before and after AAOT. And in service 2, there's a similar drop as well, although they're a slightly lower frequency attending population. What we then wanted to do was see, well, what's the effect like in the people who are really frequent attenders to A&E. So the bottom two graphs show the same analysis, but in the subgroup of people who attended more than 5 times in a year before the alcohol assertive outreach intervention. And you can see again, there's a significant drop and the effect is greater. So reassuring, and it also complements the finding from Colin's study and Tom's as well. Next slide, please. So then we looked at unplanned ward admissions because again, this group of people, because of the complexity, their high needs, high comorbidities, have frequent attendances, but also frequent unplanned ward admissions. Again, we've done a similar kind of analysis. So at the top two graphs, we're looking at the whole sample from both services, and you can see before and after, unplanned ward admissions dropped significantly. As you'd expect from service 1 that selects people who are high frequency or who have high levels of unplanned admissions, the effect is greater. And then again, when we did a similar sub-analysis, so looking at the people with 3 or more unplanned ward admissions within that group, you can see in service 1, there's a big drop in unplanned ward admissions. And actually, again, in service 2, there's a big drop as well. So we seem to be finding that the intervention itself reduces emergency department attendances and unplanned ward admissions. Next slide, please. So now just looking at the percentages, because I think they're quite stark. So service 1, we found a nearly 40% decrease in A&E attendances, a 45% decrease in unplanned ward admissions. Now, we did find an increase in bed nights, and there's a few reasons for this. There are a handful of outliers who are probably driving this effect, but I think even when we remove those people from the analysis, there is still an increase in bed nights. We think that could be for lots of reasons, and it's not necessarily a bad thing because this patient population probably need medical care but are unable to access it for lots of reasons that I'll talk about in a minute. So people are probably getting the care they need, and that's a high bed night as a function of that. It may also be because people have high social care needs. It's hard for them to move on from hospital as well. So that's something we probably need to go away and think about a bit more. And then you can see service 2 also had a large decrease in A&E attendances, unplanned ward admissions, and a slight increase in bed nights too. So because service 2 is commissioned to work assertively with people to get them into structured care, so community drug and alcohol teams, we wanted to see whether the impact or the intervention of service 2 led to a higher number of contacts with structured care after the intervention, and we're happy to say that there was a 75% increase in contacts with structured care. Another thing we found within our analysis was that the number of contacts did seem to predict successful outcome as well. So there is something about having that frequent weekly or more contact that really makes a difference. Next slide. Okay, so we've talked about the quantitative data. Next, I'm going to tell you about our qualitative analysis. So this is the data from the semi-structured interviews that we've done the framework analysis on. And we have those 3 groups of people, so staff, service users, and stakeholders. This first analysis that I'm going to talk about features staff and service user data. So first, we were interested in engagement and experience. And the first theme that came up there was complex needs of service users and their experiences with other services. So service users that we interviewed reported high rates of trauma and abuse and spoke about how their trauma interacted with their alcohol use and their ability to access services. They did report high levels of anxiety, depression, and other mental diagnoses. They often had unstable housing and frequently reported physical health comorbidities. And this constellation of problems led them to present to health services in crisis in an unplanned manner. And when that happened, they tended to have negative experiences, unfortunately. As you can see on the right, they often felt judged or dismissed and stigmatized, essentially. And that happened in medical services and psychiatric services as well. Stakeholders, staff also told us that patients were frequently refused from CMHTs if they had an active alcohol use disorder problem. And sometimes people are refused from home-based treatment teams as well. So there's something about addressing these negative experiences, and I think we'll talk a little bit as well about advocacy and how alcohol assertive outreach can start to challenge some of those attitudes. Then we looked at facilitators of treatment engagement. So service users reported that a non-judgmental and informal approach was really critical to helping them engage with alcohol assertive outreach team. This, as you can see at the bottom, this human approach, somebody knocking at the door, offering help, asking them about their lives, trying to problem solve, not just their alcohol use, but also debt, relationships, housing, physical health problems. And something about there being a persistent approach as well, which I think reflects what Tyler was saying too. That somebody doesn't just give up, they keep, even if the first approach doesn't work, you keep going and you knock on the door and see how somebody's doing. They also reported that staff with lived experience was really inspirational. So people that are currently in recovery can really offer inspiration and hope to somebody who's still drinking and give them a kind of way to model and to think about changing their own behavior. And staff told us that having a patient-centered approach was key. So tailoring your approach to that patient. Next slide, please. So carrying on with engagement and experience, AAOT was thought to have a relative advantage over other treatments or interventions for this group of patients. So the service users said that the outreach element was critical. So again, somebody coming to visit you at home made people feel more comfortable, allowed them to open up about their experiences, their difficulties. It also had some real practical implications as to removing the need to travel, which had cost implications, but also a lot of people struggled to leave the house because of anxiety and other mental disorders. As I've alluded to already, frequent contacts was listed as a really key feature of alcohol assertive outreach team, that weekly or more contact, which often people don't get anymore from any other services. And the other interesting thing is that both staff and service users really identified the fact that the AAOT teams were responsive when a referral was made, really helped them engage. So both teams can potentially see people when they're in hospital and really have that seamless transition from inpatient to outpatient care. So clinical outcomes from AAOT again touches on what Tyler was saying, and Tom too. So I think most of us would agree that this patient group ultimately would benefit from abstinence, but that's not something that's achievable first time round within 6 months, 12 months. So stabilization or a reduction in drinking or a safer level of drinking is a really important goal. And also patients talked about changes in alcohol use not being one of the main outcomes. It was also an improvement in relationships, in mood, in finding hobbies, in re-engaging with primary care. Next slide. Okay, so this is our second qualitative analysis, and this was looking at the barriers and facilitators of implementation of the model. And this takes data from our stakeholder and staff interviews. So our first theme is team culture and staff characteristics. So how does the team culture and the characteristics of the staff facilitate or impair implementation? So in terms of facilitators, well, a positive team culture was listed as really important, well-supported and skilled staff, and a learning culture. So this patient population, as I've said, have high need, lots of comorbidities and lots of risk. And something that we've identified, I think, in both sites, well, all three sites, is that there's high levels of mortality, sadly. And when you're working in a team like that, you need there to be a supportive culture where people can reflect and be honest and open and transparent and learn from mistakes. And that was key. And staff also need to feel supported through supervision and through a learning culture, which can include informal learning, such as supervision and reflection in meetings, to more formal training around motivational interviewing as well. And that having that right balance of positive team culture really helped with sustainability by retaining staff and improving well-being. In terms of barriers, and this is going to come up a couple of times, and I think again reflects some of the things Tyler was talking about. We found that staff mentioned short-term funding was a real challenge when it came to retaining staff, so people being on 12-month contracts. There was also a lot of reflection on how limited funding and actually cuts to funding can impact the multidisciplinary team. So what came out of all our analyses is that the MDT is really important for lots and lots of different reasons. And sometimes there's this, as described in this quote, a race to the bottom when it comes to reducing funding, and you end up stripping the model back to something that isn't high fidelity anymore. Okay, next slide. So then we also looked at systemic partnerships and interagency communication, and it was felt that a key feature of AAOT is that they're engaged, that they have good relationships, and that they advocate for their patients across all relevant providers, including GPs, hospitals, and local authority. This was seen as a way to challenge some of the difficulties that the patients were facing, and also ensuring that they're able to access the care they need. In terms of an adaptable model driven by research and evaluation, well, this is this slight tension between having a model that is high fidelity or high quality, but is also adaptable to local needs. And one way that services can do that, and I think this is one of the things that's come out of this research project in Manchester, is that determining what data you have and trying to improve the quality of the data that you have in order to do research and evaluation is really important. Off the back of this project, we've held two big dissemination events with our local commissioners, and that's led to some really useful discussions and developments around how to sustain and develop the teams, and has led to some changes as well, including improving the MDT. Okay, next slide, thanks. So we've just published our first paper on that analysis, so the one looking at the barriers and facilitators. It's in alcohol and alcoholism. So if you are interested, please do look it up. There's plenty more detail there. And that was published this year. Thank you. Next slide. All right, final qualitative analysis. So there's some overlap to what I've been talking about, but we finally wanted to look more at fidelity and sustainability. And we wanted to have the discussion as to what was important about a high fidelity AAOT team, and people were in agreement that the 6 criteria were important, that generally a service that adhered to those 6 criteria were most appropriate for substance users with complex needs. People had differing thoughts on the duration of treatment, on caseloads, and on the need to have clear referral criteria. And perhaps that feeds into the adaptability argument as well. In terms of the barriers and facilitators of the sustainability of high fidelity AAOT, well, again, funding and commissioning is probably one of the major barriers. Services have seen cuts over the last 5-10 years more. There was reflection on what was beneficial about the multidisciplinary team, and one thing that came out was psychological formulations, access to psychiatry as well, making sure the whole team are supporting the individual recovery coordinators to make sure that they're doing the best work they can and they feel supported to be creative and to advocate for their patients. And then the thing that we've not really talked about so far was where detoxification comes into all of this. As I said, abstinence would probably be the preferred outcome for most people in this cohort when possible, if possible. So looking at detoxification pathways early within their care is important, but this could also lead to potential bottlenecks depending on capacity within the system. Most people in this cohort will likely need detoxification in a specialist environment because of the complex nature of their needs. Okay, next slide. So there are some limitations, and I'm nearly finished. We used the first treatment episode to identify our patients. So it may be that service users who have such complex needs require more than one attempt to engage with treatment. There was the pandemic during the time that we collected the data, although we believe we've got enough data before and after the pandemic to be fairly certain that the findings we've got are are true, and of course they do complement the findings from Hull and London as well. As I alluded to earlier, because we're using retrospective data, there are certain things that we would like to be there which unfortunately aren't there. But that's something that we can learn from, including making sure things like the TOPS are used across all services as well. Next slide. So to summarise, the reductions in A&E attendances and unplanned ward admissions that we found replicate the earlier findings. The relative advantage of AOT is that it's attributed to the non-judgmental, persistent and person-centred outreach approach. Short-term commissioning cycles, high demand and staff retention are important challenges to the sustainability, in particular of high-fidelity AOT, and stigma remains a significant factor in barriers to treatment. That's it. Thank you.
Thanks very much, Stephen. Of course, you'll be coming back at the Q&A if there's questions for you. Just to remind people, use the Q&A button at the bottom of your screen if you want to add a question. We've got 7 in there at the moment, but if you want to add to that, please go ahead. So I'd now like to hand over to Professor Amy O'Donnell, who's going to introduce implementation strategies and the role of communities of practice.
Thank you, Colin. So as we've highlighted throughout the presentations so far, the MHIM programme of work was very much an implementation focused endeavour. So we really wanted to try and encourage interventions and practices that we know have a strong evidence base into real world delivery. I'm going to focus now about the strategies that we used in this particular project and look at the role of communities of practice within that specifically. Next slide, please. So what exactly do we mean by an implementation strategy? There's lots of definitions out there. This is one quite standard definition from Proctor, who describes it as methods or techniques that are used to enhance the adoption, implementation and sustainability of a clinical programme, practice or intervention. And implementation strategies encompass a really wide range of different kinds of activities. They can be sort of top down, so led from sort of senior management or driven from the bottom up. They can be push, pull, or use carrot or stick tactics. So, incentivizing or disincentivizing particular behaviours or practices. They can also involve using one specific implementation strategy, so a kind of a single action or initiative, or they can be multifaceted, where they use a combination of lots of different kinds of strategies. Next slide, please. So there have been academic attempts over the years to try and kind of define and categorize all the different types of strategies that one can use. One well-known attempt in this space is from the expert recommendations for implementing change study, or the ERIC study. And they sort of synthesized a lot of kind of literature in this area and identified a massive 73 different possible types of implementation strategies. I think what's maybe more accessible is in the second stage of this bit of work, they clustered them into broader themes, and these suggest that there are 9 sort of broad categories of strategy, and this slide lists those here. I'm not going to go into this in too much detail. The papers, if you're really keen to learn more about implementation science and strategies, there's links in the slides. Blossom Fernandez will talk a bit later about how they used the ERIC framework and EPIS in particular to inform the evaluation and implementation components of the MHIM programme. Next slide, please. But thinking about this project in particular, when we sort of reflect on the different practices that we tried to include in our implementation efforts, I think it's clear that we use multifaceted approach. We did lots of different things to try and speed up the kind of the adoption and delivery of alcohol assertive outreach treatment. So some of those would probably come under evaluative strategies. So as evaluation teams, we developed protocols that helped us closely monitor and evaluate implementation efforts. That meant that we could step in and troubleshoot if we identified issues that were arising. And I'm sure that Tom and Stephen can probably give some examples of where that happened. We carried out a whole range of different sort of relational work, so building up relations with stakeholders. That includes the work that we did with people with lived experience that Lucy will talk about shortly, as well as lots of sort of professional stakeholder engagement, sort of with policy and practice contacts. We built academic partnerships, both providing implementation and technical expertise, and that was primarily between our site teams and the MHIN central programme team. And that really helped share knowledge and expertise from people who've been involved in this field over the longer term. So Professor Drummond, for example. But I think it also really helped build a relationship between the sites that I think has been really important and critical in the kind of the success of this project. To some extent, there were some financial strategies that were used. You can't implement a new service without gaining support from local commissioners. And in Hull, for example, they've worked really closely with the local public health teams so they could access funding to actually allow the service to be set up in the first place. But I think what has been really a key innovation amongst all these different approaches was the fact we established a community of practice as part of the project for people working on the front line. Next slide, please. So communities of practice are essentially groups of people who have a common sort of professional objective, who meet regularly to support each other, to share, to create knowledge and explore innovations and opportunities. In the research around communities of practice, one of the key writers in this area sees these as having three fundamental elements. So they need to all be built around a shared joint area of interest. There clearly needs to be a community level. It needs to allow interaction, relationship building, and some negotiating meaning around what the purpose is of the community amongst its members. And it also needs to take place. It needs to be sort of in real world practice. They need to, over time, produce this kind of shared understanding, build resources, and get these kind of part of the collective practice. We know that within healthcare in general, we've seen communities of practice introduced to, for example, train healthcare students, to share knowledge amongst healthcare workers, facilitate uptake of evidence-based practices. Next slide, please. So within this project in particular, we saw communities of practice as a promising methodology that would help us bring together our implementing sites to support them to sort of tackle the so-called wicked problems as they work together to implement assertive outreach. The central project team at MHIN helped support setting this the community practice up, alongside some of the kind of the technical support in convening the community practice meetings, working closely with the sites. So they helped with the sort of the organisation, sending out invitations, facilitating the initial meetings as needed. But in accordance with the kind of the ethos and model of communities of practice, the aim and the ambition was that anything we set up during the lifetime of the project would have the capacity to continue. It would be a legacy of this work, and it would be led, managed, facilitated by its members. So the first steps in the process were to set up communities of practice design meetings, and we did this with some of the internal team, as well as people involved in implementing the service in Hull and Manchester. And those meetings looked at things like, what was the purpose of this community? What was it going to achieve? How did it align with the wider MHIN programme? Who were we going to invite? Who was that community? Who had the right expertise? Who could help us get the initiative off the ground? We also needed to think practically how we're going to facilitate meetings, who had the skills, the admin skills, the technical support skills. So those meetings led us to decide really that our community of practice would be for frontline workers primarily. So the people who were directly involved in implementing assertive outreach in Hull and Greater Manchester. We wanted there to be devolved and shared responsibility for the community of practice across its members. And this meant that the central project leads, the people who commissioned the service, wouldn't have an oversight or kind of leadership role. They wouldn't be involved in planning or decision making. It was all about what the members wanted and what they saw fit to take forward. And this is a really key principle of community of practice model. Next slide, please. So we held our launch event, and in that session, we introduced the concept of a community of practice, what the purpose was going to be for this particular community, what would the membership be, as long as sort of practical considerations, how long were these going to be, how frequent, what the format was. And we also used that initial launch meeting to have a discussion around, what were the issues that people wanted to talk about in future meetings? What were these wicked problems that frontline workers were facing? And these are listed here on this slide just to give you a flavour of some of the challenges that cropped up in that first meeting. Next slide, please. So since that launch, sort of gone from strength to strength, there've been 5 further meetings. And I think over time, we've seen the members involved really build their confidence in the approach. So initially, a former core MHIN colleague very much sort of steered and facilitated Afra, but she has since moved on to a different post. But we've really seen that the members themselves have taken over and really run with the approach. We've rotated the leadership and the planning. We've invited experts by experience to get involved. So it's really sort of flourished since that first launch. The focus, the topic focus, the members involved varies, and I think that is to be expected. These are busy kind of frontline folk, but in every meeting there are some core components that we try to make sure that are included. So we try and have some space for members to reset and think. They use mindfulness techniques in that sort of spot on the agenda. And I think for some, this was quite a new and novel way of approaching a meeting, but I think most have really appreciated that sort of breathing space that it gave us all that moment to sort of reset from the busy day-to-day commitments. We've used smaller breakout rooms to help people feel a bit more comfortable to discuss issues, but then also making sure there were opportunities for the whole group to come together. As I've highlighted, we've always had a member-led focus. So the topics, any external invited experts, etc., is always driven by the members themselves. And I think it's safe to say the feedback has been overwhelmingly positive. Next slide, please. So going forward and looking beyond the lifetime of the NHIM programme, we hope that this kind of shared responsibility, this sort of team approach to the community will really help ensure the sustainability of the community of practice. It's really important that no single person bears the burden of maintaining such a group. Things that we're talking about and considering are around opportunities to grow the membership beyond the initial sites. I think at the moment we're moving quite slowly in that direction, just to ensure that we don't kind of jeopardise the community that's already built with the Hull and Manchester teams. There's always some challenges around how to best include voices of lived experience, particularly around issues of remuneration that do crop up. I think there is a desire at some point to have these meetings face to face, but again, that's a time and that's a money challenge, but that's definitely something that stays on the agenda. So next slide, please. Just to sum up from a sort of project lead perspective, as an implementation strategy, I think it's been really effective. It's helped bring together people who otherwise wouldn't have connected, wouldn't have had the opportunity to connect. And it gave those individuals an opportunity to think deeply, both alone in that kind of breathing space moment, but also with others who were in a similar situation, and that they had the opportunity to come up with their own decisions and thinking around how to tackle any changes or challenges that they'd come across in their service. And I would hope that most involved would recommend the approach, who are also looking to implement sort of new novel practices in their sort of sector. But it is something not to be taken lightly. There a lot of work went into setting up this community of practice. They require a lot of time and effort, particularly at the outset. So if people are going to take it on, they need to bear that in mind, and also ensure that they do kind of maintain fidelity to the ethos of a community of practice model as they do so. So next slide, please. And I, at this point, would like to hand over to some colleagues who've been more directly involved in the communities of practice and the AIoT work in general to share some reflections. And I wonder if I could hand over to Stanley first, who's going to give us really a sort of a story about one of the service users to show from that perspective what the kind of the real impact of assertive outreach treatment can be on someone's life. So
thanks, Amy. Yeah, my name's Stan Matthews. I work at Salford Royal for the high impact substance use team. I'm just going to talk about one of our patient service users that we've come across, and this is just general. This is could have picked anyone. Her name's Chloe. She's a 41-year-old lady, and we was working with her from February 2024, early February 2024, up until November 2024. She was really, she'd made, in them 4 months, she'd made 9 attendances and 5 admissions at Salford Royal Hospital. We did go over and see her at the hospital and talk to her about our service and what we can offer and what we can do. She did talk to us in the hospital, and a lot of the people do, a lot of the patients do speak to us in the hospital. She spoke to us well in the hospital. And when they get discharged, she got discharged, we arranged to go home and see her. When she got discharged, we went round to her house for the first meeting, and the front door was smashed in. It was boarded up. There was no way of gaining any entry. We was banging on the door, banging on the window. Chloe came to the top window and said, you have to go around the back. We went around the back and we found out that the police had smashed the door in so the ambulance could gain access to get her to hospital. So it was understandable why it was done. When we did go into the house, I could see certificates on the fridge freezer from Achieve about what she'd done in recovery. So she'd previously been in recovery, and we'd already looked and researched into her past. We knew that she'd done rehab, a 3-month rehab at Thomas in Salford, and she'd also done two detoxes at the Chapman Barker unit. When we did get talking to her, she was still drinking heavily, and there was no change in her alcohol habits really straight away. But we did gain trust, and that's how the trust started, the building up the trust relationship. On one of the days we came in to see her, on the 3rd or 4th occasion, one of her big issues was the universal credit. So we phoned universal credit while we was with Chloe. She gave permission for me to speak. I spoke on her behalf. And did take a good few hours. Within a couple of hours, we'd sorted out all her universal credit issues, and she had an appointment to go to the DWP to see them in person, sign everything, and then everything would be started. That really cemented our relationship, and she worked with us from then onwards. We could see pictures of her family life, past family life, which was happy. She had 2 children. One was 17 at the time, and one was 12. They're now 13 and 18. Boy and a girl, and they was living with their paternal grandmother. So she had a good relationship with the kid's dad, mum, and they was living with her. She was happy with that. I did speak to the paternal grandmother on a few occasions. She knew what the situation was with Chloe, and she was happy to support us as well. So we were building up more of a stakeholder issue with her. We finished working with Chloe in November. After we started working with her in February, she had 2 more admissions. She had one for 2 days in April, and she had one for 2 weeks, which was the longest admission that she'd had. And that's because she was sober at the time. She'd stopped drinking, and she started working with us. And from when she was admitted on that day until when she was discharged, she's not drunk since. We discharged her a few months later in November, and we've still been in contact. She comes back to our drop-in group occasionally. And that was just to give you a flavour of what we do. We've been doing it a long time at Salford Royal Hospital. We're the longest running one, so we've got practices in place and routines in place that we use all the time. I'm going to pass over to Christine Hayes from the Big Light Group, who we work with as well, and she's going to talk more about the COP and the COP meetings that we go to and what we're doing there, which is fantastic as well. I'll leave it there.
Thank you, Stanley. Christine, I don't know if you want to just take over freeform, maybe start and tell us a little bit about kind of your role and how you got involved in the community of practice.
Yeah, thank you, Professor O'Donnell. I'm not sure if you can see me, but hopefully you can hear me.
We can hear.
Oh, good. So I just, most of what I'm going to say is it'll just reiterate what you said and earlier what Dr. Mills said. So as part of being a member of the communities of practice, in general, I feel that it's been an extremely positive experience and from the start, and continues to be a positive experience. I'm sorry, I forgot to say who I was. So I'm the team leader for the Salford and Trafford Assertive Outreach team. I know we're focusing on Salford at the moment. I think Nev's here, he's the Bolton team leader. And so I've been an outreach worker for a number of years, and as I say now, I'm lucky enough to be the team leader. And it's made me aware of our service delivery, and it's helped me to evaluate and improve certain aspects of what we do just through having the meetings and being able to have those open discussions. I think sometimes you just come to work, you open your laptop and you see your diary and you just go in at it and that's it, so having that time to sit back and actually think about what we're doing and having a discussion with people who are setting up a new service has definitely given us the opportunity to, as I say, evaluate and look at what we're doing, not just for the clients that we see, but also for colleagues, which was something that Dr. Mills said, the worry about staff burnout, we as he said, that, the vicarious trauma that we can sometimes just put it down to one of the, it's been a bad day, but in fact, the clients, it's not just the clients, the welfare, it's the staff welfare. And I think that was one of the things it made me realise was something perhaps I didn't do often enough. So it was, in that respect, it was good for me, which can only be good for the whole team. The visiting clients in their own environments can be extremely distressing. You know, you talk to people over the phone, and they can sometimes tell you what you want to hear. But we're very lucky that we're able to go and meet people in their own homes, as Stan has just told you, which is quite shocking. You know, but it can be distressing and it can be difficult to manage as staff. And when you said those, you know, those wicked problems, we had the opportunity to discuss that and to realise, you know, it's not okay. It's okay not to be okay, you know, and it's okay to say that too. And again, I think having the opportunity to come together and admit that, you know, there's nothing wrong with being able to admit that I find this difficult. I'm finding it difficult to go back and see this lady every day. I'm having difficulty closing this client. You know, you can't help but build up a therapeutic relationship, and sometimes it's just not the right time for that client, and having to walk away can be heartbreaking. Again, it's having that opportunity to talk about it and realize, you know, you don't have to carry that burden, you know, as the outreach worker for that client. So I think for me as a team leader, being part of the COP and having these breakout rooms and being able to discuss all these little wicked problems, it's made me, on a personal level, it's made me hopefully a better team leader. You know, I'm able to bring this up in supervision. It'll be an agenda on the team meetings. So we are aware of what's going on for everybody. You know, we continue to have trauma-informed sessions with a psychologist who works with Achieve. You know, so we're doing our best to support the teams who can only then support the clients better. So the knock-on effect is great, and having the opportunity to share that with people from different areas is amazing. So some of the barriers to have been encouraging the staff to get involved, because they're always too busy. You know, it's like, oh no, I haven't got an hour to spare. I haven't got half an hour to spare. I've got a million clients to see, you know, that's been the hardest, giving them themselves permission to actually attend those meetings and realize how beneficial it is to them. And I think once people have attended and they realize the benefits of being involved, then obviously that they come back. So that has the too busy thing was probably the biggest barrier. And again, having the voice of the client has been another benefit to the team, to our team. You know, sometimes we just having that the confirmation from the client that you're doing the best possible job you can. You know, it's good. We don't always have those positive affirmations, and also the things. It's you know, that it's a level playing field, and we can all say what we want. You know, we're appropriate. We're not there to criticise. We're there to support and assist. But you know, the things that clients don't like, and it's good to hear that too. You know, we are persistent, and that can be annoying. But you know, but there will be things that, as a team, that we think we're doing well, and find out that possibly we're not doing well. So that has been a huge positive for a learning for the team as well. Sorry, I think that's it really. I know.
Thank you. I'm so sorry to interrupt. I just know that we're on a timeline. I think, you know, both yours and Stanley's pieces have really underlined that kind of relational aspect, and how, you know, that really supports the service users, but that we also need to remember the needs of the people who are delivering the service as well, and their emotional needs. And maybe there might be opportunities to pick that up now in the Q&A that I think Professor Drummond is going to chair.
Sorry, I just...
It's fantastic.
Thank you very
it's
much.
really helpful. Thank you.
Thanks very much. Perhaps if we take down the slide and if we could have all the speakers from the earlier session come up on screen. And I think we've got Kelly, you've been looking at the questions as they've been coming in. Do you want to field a few questions for our illustrious panel?
Yeah, sure, Colin. So the first question is, assertive outreach regarding alcohol and other addictions has been going on for several decades. How can it be described here as a new model of care? And I think, Stephen, you kindly said that you will answer that question. Stephen, can you?
I'm not sure I did, but I'm happy to give you.
Sorry, no.
But don't worry, it's all good. It's all good. I mean, I guess I'd say that, yeah, the principle of assertive care definitely has been around for a very long time, in particular in mental health as well. I suppose what we're trying to say is new here is perhaps how it's been conceptualized and having these 6 criteria and looking at the quality of the alcohol assertive outreach team model. So that's probably the newer thing, and looking at how that intersects with sustainability, implementation, and outcomes as well. But Colin, you might want to add a bit to that.
Yeah, I mean, well, as I said in my talk, you know, the assertive outreach model's been going on for decades, primarily in the United States, later in the UK, for people with a primary mental disorder or homelessness. What's different here is that we're focusing on alcohol dependence without people necessarily having mental health comorbidity or homelessness as part of the picture, though some do. And I think the other difference is that, you know, until a few years ago, this approach hadn't really been properly evaluated or the effective ingredients identified. So I think that's what the new contribution is. You know, identifying the key ingredients has helped us to define what we mean by high fidelity or high quality. So it's not a new model. There's nothing new under the sun, just a new application. Okay, next one.
Thanks, Colin. So next question, how can you reduce the average caseload of 50 to 100 to 10 to 20? It seems like a big barrier. Anyone?
Tom, maybe?
Tom?
Yeah, I think it is a particular challenge, but I think we were fortunate enough to be working in a collaborative approach between the funders and the service providers that recognize the importance of a new intervention for particularly bespoke and tailored care for very high need individuals that were being identified more and more frequently in the hospital and failing to engage in services in the community. So I think it was a collaborative sort of agreed approach that attracted new funding. I think it was very hard for the service in some respects to pick up a new model, and they needed a lot of help and support to actually develop a new model with the use of things like standard operating procedures and quite a considerable coaching through the communities of practice. So whilst it is a big ask, I think with the focus on needs assessment and identifying particular outcomes, it's been a successful venture in Hull.
Thanks, Tom. And of course, it is more expensive than standard care. Do you want to say something about that, Amy, from the health economic point of view? Maybe more expensive, but it's more cost effective, right?
That's right, paying in order to save. I was also reflecting on this question as in how do you reduce your caseload? Because I think in a lot of our circumstances, the services were actually set up with the intention of having the small caseload to begin with. So I don't know, it'd be trickier to reduce down from pre-existing high caseloads. So this is very much, again, the high fidelity model that came through as cost effective in my economic evaluation, and obviously yes, the service is slightly more expensive, but the savings that come through are very much in terms of reduced inpatient care. So it's a cost effective service, and convincing local commissioners that those savings to the NHS are worth having.
Thanks. And probably important to say the savings are more about, unplanned emergency admissions by ambulance through A&E rather than reduced admissions for detox, because what we're trying to do is increase the admissions for detox while at the same time reducing the unplanned care. Okay, that's great. Kelly, what have you got for us?
Next question, assertive advocacy is an interesting finding. Can you recommend any training or training providers on this?
I can do this. We had, as part of developing the toolkit, which we're going to be talking about earlier, we've been searching quite a lot for some advocacy training, and surprisingly haven't found very much, which is focused on people who are alcohol dependent or with substance use problems. So this is something that we're going to be developing for the toolkit so that it is bespoke and relevant to AAOT, and this is going to be included in the toolkit.
Thank you, Tyler. So next question, can you give any data on the average face-to-face contact per week? I note the Fidelity scheme says a minimum of once per week, but the person's interested to understand more details on the intensity of contact.
Yeah. Oh, sorry.
Sorry, Tyler, go ahead.
Well, this is something that we did look at, and there was a mean of 37 contacts over 26 weeks, and this worked out at 1.7 contacts per week per individual who we sampled in the case notes, and the average duration of this was 1 hour.
Maybe you've got similar findings from London.
Yeah, I think our mean was 63 over the 52-week period, and indeed Mary and I have been in contact in the chat about this as well. So,
okay, and Stanley.
Yeah, I'd just like to say that when we go out to see people, usually in the first couple of weeks, we'll see them 2 or 3 times a week because they're so chaotic, and then only it lessens to 1 a week once we've established a rapport and once we've moved on, and then it can be once a fortnight. Even at the end of it, it can be even less, and you can spend more time on the patients you're working with initially. So it's all dependent.
Yeah. So I think the emphasis is on flexibility, isn't it? Responding to how the patient's presenting at a particular stage in the journey. I mean, we had a lot of people who ended up in detox or rehab, so we were able to reduce the contact frequency quite a bit while they were, receiving other care. But that allowed us to be more intensive with people at an earlier stage. Great, that's really helpful. Thank you. Okay, what else have we got, Kelly?
Okay, so it is an NHS addiction service sitting in a mental health trust managed by Addictions. Has anyone got any comments on that statement?
I think that was a response to a question, actually.
Right.
It's a
okay.
statement.
Okay. So
yeah, I mean, yeah. we have different models across the different sites, don't we? So in London, it was a mental health NHS trust that hosted the Assertive outreach team. But in Hull, I think we had CGL as the provider, but working closely with NHS acute services. And then Manchester, you had 2 different models, didn't you?
Yeah. Well, in Manchester, we have a mental health trust that's overseeing all of the services, and they subcontract to local acute hospital trust for the HISMIT team, and to third sector organisation Big Life for the other service, which Christine and Stan are from.
Okay.
Okay. Next question: is there any evidence or data surrounding alcohol-related deaths and patterns in piloted areas?
Yeah, we can say a bit. I mean, OHID does provide the Office of Health Inequalities and Disparities, as was Public Health. It does provide data, as does the Office of National Statistics, on alcohol-related specific deaths. They are high in our area, so there is trend data in that. But particularly and specifically to the AAOT service that we operated, over a 6-month period, we had 6 deaths. And that was reflective of the very high levels of physical comorbidity, particularly in our patient group. And was something that we picked up quite early in terms of the vicarious trauma that Tyler mentioned and need to support staff. Because often in traditional services, people in a very acute physical illness don't actually access the services. So it's perhaps less obvious around the sort of the immediate death in service, perhaps of some of the patient groups. But it was a particular theme that came out of the need for supporting staff.
So we've also been tracking the key indicators of alcohol harm in Lambeth and Southwark since we introduced the service. And since we started, Lambeth and Southwark went from being the highest rates of deaths and hospital admissions due to alcohol to being low to medium in the rest of London. So assertive outreach wasn't the only initiative that was going on at the same time. We've had, alcohol care teams in the acute hospitals as well. But, I think part of it is that we've targeted a very high risk group and engaged them in treatment, whereas previously they may not have engaged in treatment and would have been more vulnerable to dying of alcohol causes and or being admitted frequently to hospital. So we're going to explore that in more detail. Certainly there was an impact at hospital level and reduced admissions. Okay, good. Anything else, Kelly?
If you've got time for another question, Colin, I can carry on. So were there any findings across Hull and Greater Manchester around interaction and dependencies between AAOT and alcohol care teams in hospitals?
Go first, Stephen. Yeah.
Well, yeah, all I was going to say is we haven't looked at it specifically in this study, but anecdotally and from our interviews and from discussions with colleagues, and Stan and Christine can fill us in as well. The AOT teams do work closely with the alcohol care teams, but we haven't explored that relationship yet in our study.
And ours at Hull was specifically linked to the alcohol care team, which expanded under the NHS England funding. So as a consequence, we wanted to sort of develop a system of care that was linked to both of them. That said, people who were referred to the Assertive team also were individuals who'd been referred into the community but failed to engage in traditional services. So we had 2 pathways really, one from the alcohol care team and the second one from previous referral dropouts really.
I can just say from our point of view, from the high impact substance use team, we've got 1 foot in Salford Royal and 1 foot in Achieve. So we do both, and we notify on both as well, and we duplicate all our notes and everything to go on to both systems.
And we have in-reach clinics at a number of hospitals across the footprint, and we have good relationships and easy pathways for referrals as well. So and we make sure that we contact a client that's been discharged from hospital within 24 hours. So we try and keep that warm handover going as well.
Great, thanks. We've slightly run over our planned Q&A time, but what I'm going to do is just draw this to a close now, give everybody 5 minutes for a comfort break. We can come back in 5 minutes. And I'd just like to thank everybody who's spoken so far. If there's questions we haven't picked up so far, we can maybe pick them up in the second Q&A, or we could answer them directly with you after the session. So see you in 5 minutes.
a bit more about the implementation science-informed learning around the opportunities to sustain AAOT. And a little later on, we'll hear about the implementation toolkit that the teams are developing. We'll hear a bit about our patient and public involvement activities, and delighted to be joined by some of the service users here who've been part of Project 3. And then we'll have another Q&A session. So do add your questions to the Q&A that you can see along the bottom of the toolbar, and we'll pick those up then. And then myself and Colin will wrap up. So if I could now hand over to Blossom Fernandez, who is going to talk about the evaluation.
Thank you, Amy. Hi, everyone. I'm Blossom Fernandez. I'm a research fellow on the MHIN's evaluation workstream, and I'm based at London School of Hygiene and Tropical Medicine. And I'll be talking to you a bit about MHIN's program evaluation, which is supported by a lovely peer researcher, Amy. And this workstream is led by Professor Annette Bowers and Dr. Shalini Ahuja. So to give you next slide, please. Flavia, thank you. So to give you an overview about our evaluation, we had two main aims. Firstly, to conduct a program-wide evaluation of MHIN, focusing on the relationship between prioritization and implementation and the support that was provided by MHIN to its partners, and how this might have impacted sustainability, and then further on evaluating sustainability as well. Secondly, we wanted to offer evaluation support to MHIN partner sites, be it through capacity building sessions such as forums or webinars, or support as needed. Next slide, please. So this is what MHIN support looked like. It began at the executive and advisory boards, and this support was developed iteratively in that it was in response to the evolving program design, the choice of priority areas, the interventions, and ultimately site need. So the support was ultimately delivered via our partners to the implementing site, for example, schools and addiction centers, with the outcome of ensuring well-being of service users. So moving on to the next slide. So this is what our design looked like. So we wanted to conduct a process evaluation to see what works and for whom. And so this would also complement local evaluations, so evaluations that you've heard about today. So this was a multi-stage mixed method study. And by that, I mean that we conducted different forms of evaluation. So semi-structured interviews with our stakeholders within MHIN and with MHIN's partner sites. We conducted meeting observations, and we also looked at event documents such as meeting notes. And then we used a thematic approach to analyze this data. And we firstly inductively identified themes and then mapped these deductively onto EPIS framework, which Amy mentioned earlier. And I'll be exploring it a little bit later on. Next slide, please. So again, Amy mentioned ERIC, so the expert recommendations for implementing change, ERIC as it's known. This is a framework which is a compilation of implementation strategies and 9 domains as identified from a large-scale study from a wide range of stakeholders with expertise in implementation science and clinical practice. So from those, the ones that were relevant to MHIN are quite clear, and they're around providing interactive assistance, adapting to context, developing stakeholder relationships, making sure stakeholders have the skills, so they have the resources, and when needed, that change is enacted. And we did that through research skills, building relationships, providing resources, like I've mentioned, and making sure the team are capable with their evaluation or implementation. So there were 2 types of support delivered by MHIN, implementation and research. Next slide, please. So now moving on to EPIS. So we mapped our qualitative data from our initial program-wide evaluation onto this EPIS framework. Now, EPIS is the exploration, preparation, implementation, and sustainment framework. And EPIS has 4 well-defined phases that align with the implementation process. So the exploration phase mapped with the prioritization phase of MHIN, the preparation phase matched with our intervention and ARC selection phase. And the implementation phase is linked to the delivery of MHIN chosen interventions. And finally, sustainability matched both the intention and planned activities by our partners. So within this, we noted there were several EPIS and overlapping MHIN themes. However, we highlight the prominent themes for MHIN, which is relationships, communication, and timescales. So these are important factors that stakeholders identified for MHIN in its strategies. So next slide. Thank you, Flavia. And so moving on to sustainability, we wanted to explore factors that influence and impact the long-term sustainability of these interventions, these mental health interventions like AOT, which were implemented by MHIN or supported by MHIN even. And again, our design was similar. It's a multi-stage mixed method study. We looked at qualitative data retrospectively, so existing qualitative data that we had around sustainability. And these were from semi-structured interviews. And we also conducted a sustainability survey. Now, the sustainability survey would help us identify sustainability features of an innovation. This was devised by the NHS. And we used a thematic approach again to identify common themes and then deductively map them onto EPIS. But today we're just going to look at the sustainability portal diagrams and some of the early qualitative data. Next slide, please. So this is a portal diagram that's been created from the NHS Sustainability Survey. Now, this survey showed us that, as you can see quite clearly, leaders at clinical level and at senior level are considered highly involved and supportive of sustainment. And they use their influence to communicate the impact of the work. So there's that, but alongside that, there's also support of the organization, which also drives sustainment as staff are then trained in the new ways of working. We do note that, the staff have low scores on enacting change, in that they do not feel as confident in, suggesting adaptations And as we delve further, we know that this is because they join at different times. So they may not feel as comfortable suggesting these changes. So to give you a brief overview of some of the quotes from the interview data, next slide, please. Here you can see the facilitators of sustainability. So you will see that NHS is a key factor, that if it's commissioned by the NHS, then it's considered quite important in ensuring smoother implementation alongside funders, clinician staff who are engaged, and that staff who are confident, then you can stretch the complexity, as one participant says, and also maintaining communication. So just to read one quote, in terms of sustainability, we're trying to get funders, clinical staff, and make them aware of how everything works as much as we can. So again, highlighting the importance of the key teams that would drive sustainability. So moving on to the next slide. This is looking at the barriers of sustainability. And here, stakeholders highlight the key things that will ultimately slow sustainability or hinder sustainability. So we've got communication, then you've got, again, NHS working as people work in different silos, and then you've got different sites with different guides for practitioners, and then researchers working from different guides. And then finally, stakeholders highlight whether it's worthwhile. But there's a good quote from one of the stakeholders, and they raise good questions around around AOT. Is it time consuming? It's a labor intensive model, but does it get better outcomes? Does it reach more people? Does it target people? Absolutely. So yes, this is all the key quotes we have around barriers of sustainability, but we're still looking at more data. And finally, to summarize, next slide, please. We've got key findings around sustainability that shows us that leaders are key drivers, and they're respected as decision makers. And staff again highlight the importance of funders and stakeholders that would drive sustainability alongside health services and its systems like the NHS. Thank you so much for listening. I think I might have to rush on and pass it over to Lucy Gallagher, our PPI coordinator.
Thank you, Blossom, and sorry for hurrying you a little, but yes, just to keep to time because we're already a bit over, to pass on to Lucy. Thank you.
Thank you, Blossom and Amy. I am Lucy Gallagher. I am the Patient and Public Involvement Coordinator for the Mental Health Implementation Network, and I work with Jason and Amy Dunbar. So I'm sort of presenting on behalf of the PPI work stream today. Next slide, please. So this picture here is of our small team and the experts by experience that sit on the advisory board, and Kelly from our recent MHIN away day. So just to give a little bit of background to our work. So when we first started the programme, we kind of got our heads together and thought about what patient and public involvement would mean for a programme like the Mental Health Implementation Network. And for us, we saw it as a collaborative partnership between academic researchers and people with lived experience, being part of the research process. So experts by experience, or as some people refer to people with lived experience as service users or public contributors, should all have an active role in the design and conduct of research, as opposed to being seen as subjects or participants. And our funders, the National Institute for Health and Care Research, define PPI as doing with or by people who have lived experience rather than to, about, or for them. And as a programme set up to reduce mental health inequality, it was crucial that inclusive and equitable PPI was fully embedded across each of our projects, as well as this one. We have 2 other projects focusing on different areas of mental health. So upon starting the programme and through conversations with colleagues across our network and from doing our own background research, we found that there's actually limited existing guidance around PPI and implementation science specifically. So to fill this gap as a PPI work stream, we provided support centrally to each of the sites as and when they needed it. And that came in the form of many different formats, the first of which was an involvement and inclusion guidance document. And this guidance document was created to be a sort of reference point for how to do involvement and inclusion meaningfully in implementation research. So the types of things we included in that were a quiz, infographics, signposts to various other readings that people might want to look into. And then if we can go on to the next slide, please. One of our most popular resources was the Snakes and Ladders tool, which was developed by my colleagues and the PPI leads at the time, Laura Fisher and Sarah Ray, which was developed to sort of help with self-reflection for anybody looking to carry out PPI. And it got a great response, and it has done ever since we've shared it at future events. So if you would like a copy of this, that can be shared with the resources after the webinar. Next slide, please, Fabia. So I'm just going to talk briefly about what PPI and equity, diversity and inclusion looked like within the MHIN AAOT team. And Stephen and Nikki, who I will introduce properly in a moment, are going to go into a little bit more detail about their contributions to each project. But to provide a bit of a high-level overview, I've listed here the types of activities that they've been part of throughout the projects. So it's been really clear how the input from people with lived experience has had a real impact in Hull and Manchester, and therefore the outcomes of each of the projects, it's clear that there's real potential to see how there's real potential that the outcomes will actually benefit the people who are in need of these types of services. So by contributing to publications that are going to be shared between people wanting to set up an AAOT service and wider, we can really make sure that the patient voice is part of that aspect of the projects. Next slide, please. So last week we had an event to mark the end of our programme, and we brought together all of the experts by experience from each of the local project sites. And this was the first of 2 graphics that were produced by a graphic illustrator, Dr. Penelope Mondonsha. So she was there to help capture our discussions and presentations from the day. This first one is kind of summary of the presentations that were delivered by our research associates and research assistants and PPI coordinators that were at the event. And we'd asked them to present on how PPI has impacted their projects directly. So there's quite a few themes there. So for example, you know, having lived experience input right from the beginning and kind of having to think about how to balance out, you know, potential power imbalances that can occur in this sort of work. And then if we can move on to the next slide, please. So again, quite a lot of information to take in, but again, these can be shared after the webinar. We then went into breakout rooms and we discussed different areas of PPI and implementation science, namely the importance of engaging with local communities with less access to health and social care services, and the importance of this to prioritise implementation of innovations that actually benefit these local populations. We also looked at how PPI can help us to identify potential context-specific barriers or opportunities to the implementation of new innovations. And then another area we covered was the need, again, to even out power structures and recognising which voices were in the room and which voices weren't in the room from an early stage. So I'm now going to pass over to Stephen Blood, who is a public contributor on the Greater Manchester AAOT team, and he's going to just talk a little bit about his experience working in this brilliant team and how he's contributed to the outcomes of the projects. And then after that, we're going to hear from Nikki Copeland and Luke Ingemels. Nikki is a service user in Hull and has acted as an expert by experience on the local project up there. And then Luke has been sort of our PPI lead up there. So over to Stephen.
Thanks, Lucy. So I guess I would start with a little bit of my history. So next slide, please. So I thought I would give you all a bit of background as to what happened to me. So I moved to London in the first place as gay at 21. And I worked for a retailer in head office for 13 years. And my job got moved to Manchester, which I suppose when you're 21, you can make friends easily. When I moved to Manchester, it was really difficult to get people my own age to even be friends. So that's what started my drinking problem. And over time, I became isolated from lots of things. I then had a physical problem, so a heart problem, nothing to do with the drinking, it was just an aside. And I now have a pacemaker fitted, and that's kind of just what happened. So when I was in Manchester, once I got to Manchester, kind of my whole world fell apart. And so I had to try and rebuild that. So I did engage with my GP. My GP is gay as well, I think. So I trusted him, I suppose. And he referred me to Achieve. and it kind of got me through, I suppose, like a very, very difficult time. And I suppose at the time I didn't really know what to do. So kind of like Assertive, if someone had come to the house, it would have been much easier. So I was like drinking at home, and I was kind of just thinking that was okay at the time. And I just thought that was what everyone did. And I suppose if I look back to the London days, it was about going out after work, because no one really drives to work in London. So it was kind of just 1 or 2 drinks after work. But I think in Manchester, there's a little bit more of a culture of kind of people, I don't know how to put it, but kind of like laying on the street in Deansgate or whatever. Like it's kind of like just accepted, which doesn't happen in London. So I think it was really tricky for me because I'd never experienced that before. So anyway, I kind of got into the Achieve situation, so Salford situation, and they helped, and they were there within 2 weeks. And I think at that point you kind of think nothing's going to get better. I mean, I think everyone's had an opportunity, a situation where you think something's not going to get better, but I don't know, with support you do, and I suppose that's what I fight for. And I guess that's got me into starting a situation where things do get better. I had massive support from my GP, and I had massive support from Achieve. And I think it makes such a difference. So I think the pathway to recovery is kind of like you need to kind of understand the person. So I think you need to kind of sort of understand the person's issues. And I would agree that it goes hand in hand with mental health. I guess back in the day, I was going to say, you're told you can't have mental health support with alcohol help. And so it's really tricky at that point, because I think what you need is hand in hand, and that isn't always available. So I suppose why I got involved in the project was because of my circumstance at the time. I think I met the person who runs, or is part of the management team at Greater Manchester Mental Health, and she put me in touch with Dr. Stephen Carr that you've heard from earlier. And we've gone through the project together, and I think this togetherness or support is good. I think it makes such a difference. I can't really express how good that is, but it really does make a difference. Can I have the next slide, please? So I guess introduction to research. So that would be through the person who introduced me to Stephen. And it's made such a difference because it gives me purpose as to what to do, I suppose. It's really tricky sometimes, but it does make a difference. And I think without that, I'd have probably died by now. So I think it does make a difference. I guess a stepping stones to becoming a PPI lead. So I guess like making sure I wasn't drinking and was happy to do it. I think it's not that easy, but at the same time, if you force yourself, you can. I'm going to compare it to like going to Sainsbury's. It's sometimes you force yourself and that's it. So becoming that PPI lead was a lifesaver for me. And I don't think I'd be here today if that hadn't happened. But also there's kind of like the learning about what the role is and what you do. And I think that's important too. So the teaching is also amazing. I think training and I had the opportunity, I suppose, to go to the University at Manchester, and Karina, the professor, she taught kind of what research was, and there's so much diversity in the group that was there, which is great. I suppose I always think to myself, like, being gay is like you're judged, but it wasn't like that. It wasn't like that at the university. It was so good. And I think that's really important. And I think like during COVID, like there's so much sort of disengagement with other diversities, but I think it's really important. And I've learned through volunteering, I suppose, that there are so many different situations, and I think sometimes these different situations aren't considered. I think sometimes everything gets lumped into one. And sometimes one size doesn't fit everybody. So I think it's really important that the training continues, and it's got to. I think in terms of meeting the project team, I think they've been amazing over the last 2 years. There's such a variety of people from different backgrounds, different experiences. It's so important that everyone gets included. And if kind of you don't agree with something, you can raise it. And I think that's good. Next slide, please. So I think full involvement from the outset. So yes, I've been totally involved from the beginning. And I can't thank the project team enough, because I think I have been, and I feel like I've been treated like a member of staff, which is perfect. It's so worthwhile from different perspectives, I suppose. I can't describe how it's so worthwhile, and I don't really understand how you can help someone if they haven't got that lived experience. My project manager has been Nikos, has been great. He's always been there, and he's always done everything that I've ever requested, I suppose. And I think the whole team has worked so well together that I think that's so important. I suppose I see not in this project, but I see a lot of arguing within the NHS as to this department doesn't talk to that department. And I just think it's so important that everyone works together, shares notes, whatever is requested. And I think I've learned on the job. So Karina did a great teaching of research, and she taught me how to do some of these presentations. And I think it's really kind of like sometimes difficult to talk about yourself, but sometimes you have to. And I think understanding how things work is key, I guess, in terms of just being yourself, I suppose. And there's so many hurdles, but there's so many good things that come out of it. And that's important, I think. In terms of volunteering, I think it was great to do practice interviews with Nikos. I think gave Nikos and his colleague a chance to practice some of the interviews he was going to do with service users. So I think that's worthwhile as well. And I think sometimes a bit of practice is quite good. Next slide, please. Could I get the next slide, please? So I think the experience of taking part is, I've learned so much. I can't even put it into words. I think whether it's Dr. Stephen or it's Nikos or whoever, I've learned so much, and I've learned how process works. And sometimes process frustrates me massively, but I'm sure it does to them too. But sometimes that's just life, I suppose. I think it's learned that I need to focus on myself more sometimes. But taking part gives the chance to give other people's views, I suppose, as a PPI lead. I think sometimes the NHS can get caught up too much in process and not about the patient. So I think that's really important. I do have a feeling of giving back to other people. I've been through the situation, and if I can protect someone else from not having that situation, that's a good thing, I think. As I said, understanding processes and reasons, feeling part of the team, and seeing outcomes come through. So, in my opinion, research is amazing. Of course it is. But there's got to be some outcomes from the research, in my opinion. And sometimes I think research happens and there's no outcome. And I think, having heard from the people on the ground earlier, sometimes in the situation it's not working, but if we don't do the research, we can't get to that point, I suppose. So I think research is really important. Yeah, next slide, please. So to be involved, I think living experiences firsthand. So I think you you look at other people and you think of yourself, and it's hard, but you have to. And I think it's really, really hard, but it's important. And I think sometimes when someone's asking for the help, they're not getting it because there's not enough funding or there's not enough whatever. But if you persevere, you do get it. It's just about having that motivation to persevere, I suppose. And I think sometimes the patient can be spoken about without them being there, which doesn't happen. I haven't seen in Greater Manchester Mental Health. And I think it's really, really important that the patient's voice is heard. Because I know someone said earlier, like, there's 2 or 3 times people are going into hospital. Well, I'm not surprised because they're not listened to. So it's about being diligent in the first place, I suppose. Yeah. And I think the stigma that was brought up earlier is really important, because there is a stigma and that's got to change. And when I mean stigma, I mean, say, A&E staff, because sometimes they're just not. They just think, well, that person's drunk, so they won't deal with them. They might let you lay on a bed, but that's it. And I think that's got to change. So I think there's a project to do on that as well. But having been part of this project, I think it's been amazing. And I think the people in the project have been absolutely amazing. And I can't thank them enough. So, yeah, that's kind of my view.
Thank you, Stephen. Thanks for sharing your story, and also for those fantastic insights into, what you've gained, and, the importance of involving people who've actually lived, that life in research. I think we do that a lot better now, but it's something that you never can take for granted. We are running a bit over. We've accumulated lots of kind of extra fantastic insights, but yeah, we're running a little over. But I wanted to bring Nikki in now before we move on to hear from Tyler and Nikos.
Hi there, guys. So just really quickly, so my name's Luke Ingemels. I'm the Deputy Service Manager at Renew in Hull. So I'm aware we're a little bit shorter on time, but we wanted Nikki to kind of come in. So Nikki was an AEOT service user and now is a volunteer with our service. And I think Nikki's story is really kind of pertinent to kind of closing some of the comments around the impact that alcohol assertive outreach does have, and some of the good work that Nikki and some of her wider lived experience network are now doing in Hull. So I'll hand over to Nikki.
Hi, I'm Nikki, as Luke said, and I'm currently doing the voluntary work with the AOT. I'm also doing lived experience as well. So I'm going to do quite a short story of how I got to where I'm at now. I'm a volunteer, I'm working with lived experience, I'm working with Renew, and things are going forward. So originally my story started a long time ago when I was quite young, and I've been in the service for 3 years, and that was in December of 2021 when I got my first detox, and then I went on and did 4 months in rehab. However, my actual recovery, which I'm classing as my recovery now, where I've actually managed to stay sober for 16 months, started in the November of 23. I was admitted to hospital at Hull Royal Infirmary. Now, I had been there multiple times, and There was a lot of stigma attached to why I was there, about my addiction, and that is something that does need recognising, but I know that is a different part of this. So I'm going to kind of try bring you some of the positives that has come out with it all for me. So I was in the hospital and I got quite a few of the AR team who did come to see me while I was in there. I don't remember much of it, to be honest, and I know that I was in there for 2 weeks and then I got discharged. I was really quite poorly, and I was struggling with multiple illnesses, even though I'd been discharged. However, I was sober and I had been for 2 weeks. So for me, that was my main aim. I wasn't really bothered that I was ill. I just wanted to stay sober, and I was. So 2 weeks later, one of the AOT workers came to see me, and she was a lady called Louise. When she first came, I thought she was coming to see me because I had multiple admissions in the hospital. No, this was not the case, because at the time I was quite upset, annoyed. But when Louise actually explained to me what she was there for, it made she put things into perspective. And, you know, I realised at the time that this is something that is going to continue to help me on my journey. So Louise used to come see me once a week. We picked a mutual day and she stuck to it. When she first came, I didn't really engage. I wasn't engaging with anybody. I was isolating. I was just sleeping, not eating, but I was sober. With Louise's support, time moved on, and I started to feel better, started engaging more, and it became like a friendship. So with the friendship, little girls was put in place, because it was like starting a new life. You know, it really is, and people underestimate the power of, you know, this illness. So we had little things put in place, and eventually with the support and encouragement I got, which I must admit I did find really strange. I'm not the type of person who just asks for help or takes it. However, I have learned on my journey now that people need help, I need help, and I will continue to take any help I can and give help to others. So with the guidance of Louise, I started getting support mentally, for my mental health, physically, and basically time started to move on and I started to become a normal, if that's the word, member of society. I started joining groups, using other service users, going to anything that I could go to that would keep me sober. Whilst doing my recovery with Louise, we discussed about my work. Now, I did have a good job, which was held open for me, and it was working with vulnerable children in residential care. However, I did find it quite triggering if I was to go back there, because it was because of the age of the children, basically. So even though I wanted to continue doing work, helping, I knew it couldn't be with young children. So we discussed about the outreach team and the alcohol care team in the hospital. Now, because of my time in and out of hospital, I'm really passionate about helping people that are in the care system within Hull Royal, and I think things do need to change. However, there's a lot of positives out there, but people need to be made aware of them. So as time's gone on, I started doing some voluntary work with the lived experience team, and we actually put on an event 4 weeks ago at the KC Stadium in Hull. There was approximately 170 people at the event, and it was lived experience, the frontline workers and the decision makers. So this was what co-production should have looked like, and things are coming from it. We've showed what good co-production was. We've made people more aware of how many women take their own lives due to domestic violence, and the stigma about people that have got lived experience with multiple unmet needs. And this is something that, again, I'm really passionate about. And we are, as a team, letting people know out there that, you know, there shouldn't be a stigma attached to it, and there is help. I've done quite a few shares in recovery groups about my experiences, where I am able to offer support to others. I've done service within Renew as a volunteer, whether I'm just a friendly face or someone to listen to, or I also give practical support to be given so that they know how to use outside agencies. Last week I attended the Mental Health Information Network celebration with Luke, which I really enjoyed. I was really grateful, and I am grateful to be given the opportunity to go to something like that, but also the opportunities that are coming now. And I think with doing things like this, we can break down the stigma that comes with unmet needs. And I think by giving support to others that need the help, we can make them realise that we are all equals and we should be treated like that. We should all be given the equality and the respect we deserve as human beings.
Thanks, Nikki. I know that, sorry, I apologise, I know we're running behind on time, so that was a little bit more rushed, but thank you, Nikki, for your time. That was really appreciated. I'll hand over back to you, Amy.
Thank you, Nikki. Really appreciate what you said. I think you reminded us all how kind of important this is, and why we all work in this space, and why there's still more to do, I think, particularly around kind of stigma and the impact that has. We are quite a bit over time, but if I could now hand over to Tyler and Nikos, who are going to talk about the toolkit that they have been developing. We won't have much time for questions, but we'll try to pick them up as Colin and I wrap up for the day. So if you can just bear with us, that would be great. Thank you. Over to you.
Thanks, Amy. Thank you so much. And I would like to thank also Flavia and Kelly and Lucy, who have been supporting this very busy webinar. So we're going to give you an update about the toolkit that we have been drafting with Tyler and Amy Wolstenholme about the experiences of implementation. Can we go to the next slide, please? So we're going to very briefly touch upon the objectives of the toolkit, the structure that it's going to have, and we'll give you a couple of examples of how we envision it to look like when it's finalized. So can we go to the next slide? So there are a lot of materials and information about service delivery in alcohol care settings, but there's not really an extended kind of guidance on implementation and delivery of high-quality alcohol assertive outreach. So this toolkit basically tries to expand and develop the knowledge and experience gained from the research that has been taking place in the three sites, the South London, Greater Manchester, and Hull. It is also the only toolkit that adopts, in this specific area, that adopts an explicitly an implementation science framework, drawing from the studies. Although there are a lot of materials that focus a lot on care delivery, this is going to have elements that are also relevant for commissioners and managers, and not only just to alcohol practitioners. Next slide, please. So obviously, the whole content of the toolkit will be based on the research findings and the accumulated experience of the trusts and the sites, but an early draft of the toolkit was created by my colleague Laura Scholes, who shared the content with staff, commissioners, stakeholders, and members of the Mental Health Implementation Network. And we received extended feedback following that submission, and we decided then to restructure the entire draft according to implementation stages, which would encapsulate the ethos of AOT, the values, the priorities, and the principles of delivering care for people with complex needs, but at the same time, evidencing how it's different from other substance misuse interventions. So Tyler, myself, and Amy have been working in partnership for the last few months, trying to develop the toolkit. We greatly benefited from discussions that have taken place in different events. So we had 2 dissemination events in Greater Manchester. We had some discussions that were really useful in the MPhil celebration event in October in Tix College. And we conducted a workshop as well in at the Lisbon Addictions Conference with delegates from all around the world, from the United States, Denmark, Norway, Scotland, Greece, Malta. And that was extremely fruitful as well. Next slide, please. So here you can see some of the materials that were produced in the toolkit workshop we conducted in Bolton with approximately 30 practitioners, academics, commissioners, and managers. And there were very useful and interesting discussions about clinical pathways, staff training, staff development, recruitment, and how you can achieve actually a level of multidisciplinary teams that can support the delivery of high quality AOT. Next slide. So the 4 stages of implementation, which the toolkit is going to follow, are developing systems of care, developing staff, developing staff with a specific kind of anti-stigma agenda, which is really important, delivering patient care, and evaluating patient care. So I will hand over now to Tyler, who will elaborate a little bit on these stages of implementation.
Hi, thanks, Nicholas. Could we go to the next slide, please? Previous slide, please. Thank you. So yeah, I would just wanted to talk about some of the main themes that are going to be captured within each of the stages of implementation as they appear in the toolkit. So something that we've been discussing quite a lot is hospital pathways, referral in and out of AOT services, and also the importance of having the correct IT infrastructure to support this for information sharing and for safety ultimately. In development staff, these are some things that you'll recognize from what we've been discussing during this webinar is the staff culture of support, of staff support and trauma-informed care, and also staff competencies for if you're setting up a new AOT service and hiring new staff. Also, the importance of communities of practice and how to set one up, that's also going to be involved in the toolkit. In delivering patient care, as I mentioned before, assertive advocacy is going to appear in that, and we're going to be developing some training and techniques to help people deliver this. And the importance of a dynamic risk assessment was mentioned from stakeholders and staff throughout all of the sites, and this is something that's going to feature a lot. Finally, in evaluating patient care, we found that it would be really useful if services could evaluate how they're performing and also check that they're performing with fidelity to the high quality AOT model. And so for this, we're going to provide a checklist and some other tools to help services evaluate this themselves. Can we go to the next slide, please? So I'm just going to go through some examples and highlight how the ethos is woven through all of the stages of the toolkit. So this is an example from developing systems of care. And as you can see, we're trying to provide easy to access and clear summaries of some of the essential elements of care. And we're also going to be using some case studies to highlight how different sites have tackled common problems, what they've done, which has been a success, and some of the advice that they might have to give. Next slide, please. So this one is an example from developing staff, and this is about communities of practice. I think Amy earlier mentioned Wenger and the 3 fundamental elements of communities of practice. So This is just to demonstrate how the toolkit is highly evidence-based, and we're providing tangible recommendations for people to implement when setting up an AOT service. Next slide, please. This is an example from the development staff section. And in the toolkit, we are trying to provide some interactive tools that AOT practitioners and new services can use to make sure that they're performing as they expect to and meeting the fidelity to high quality. And this has also got clear links to implementation strategies from the literature, such as facilitating debriefing and clinical supervision for frontline staff, which I think was also mentioned earlier. Next slide, please. And this is just some final examples. The first one is from development staff, and the second one's from delivering patient care. And this is just to show some real life examples and perspectives from people who have sort of been there and done that, just to help new services and teams to contextualize the recommendations that we're going to be providing in the toolkit. And so the next steps for this are to work with colleagues to design the toolkit further. This is going to go through a further process of review before it's ultimately disseminated. So thanks for listening to us today. I'm going to hand over to Colin and Amy to close the session.
Thank you, Tyler and Nikos, for your timely delivery there. Great piece of work. And I think the fact that we've struggled to keep this on time just shows what a kind of really sort of wide-ranging, complicated and collaborative piece of work this has been. There are lots of things that we wanted to share with you. Do we have time? I think there were just one or two questions that weren't answered in the previous Q&A. So I wonder if we could maybe...
Yeah, I've had a look at them, Amy, if you want me to.
Yes, please.
Quickly.
Yes.
Yeah.
Thank you.
So Simon raises a really good point about mental health trusts tend to be focused on what they see as their own narrow outcome responsibilities and also their own costs. Same's true, I think, for acute hospitals. You know, they tend to be sort of quite happy to see the results that assertive outreach produces, but they're not so happy to pay for the service, you know, which is addiction services are traditionally commissioned through local authorities. So this is where I think linking with integrated care boards is really important, because they have an overall responsibility for the health and social care being delivered locally. And our experience so far, certainly in Manchester, Hull and South London, has been that they're quite open to thinking more broadly about system changes or system interventions that could have an impact, rather than the sort of model where everything's very focused on one sector or another. So thanks for that, Simon. Dominic talks about the difficulties of getting people with alcohol problems and comorbidity, mental health comorbidity, accessing mental health care, and that is a real challenge, as we all know. Certainly the way it's been addressed within assertive outreach in South London is the assertive advocacy that we've been talking about so much this afternoon. So making sure that our assertive outreach practitioners identify unmet mental health and physical needs, and then advocating with the services to help people to gain access and to overcome the barriers to access. And we've managed that with some success. But I think ultimately it's about changing the culture so that, you know, mental health services work more in a more integrated way with addiction and vice versa. But yeah, it's something that is very much on our minds, and it's something that I think assertive outreach is well placed to help with. And the other one was about sort of what about better psychological therapies, and absolutely we need better psychological and pharmacological therapies. But what assertive outreach is about is getting people to engage with therapies that are available, you know, where they otherwise wouldn't have done so. So we're very much about helping people to access those services in a way they've been unable to do up to this point. But yeah, I agree. You know, we could also continue to improve the type of offering of psychological and pharmacological treatments. But if people can't access them, then they're not much value.
Agreed. And I think in all our other work, we're all doing sort of research in that space, and I agree it's hugely important. We're almost out of time today. I know that there have been a couple of questions, I think, posed around when some of the outputs will be available, for example, the toolkit. And I think Lucy is going to circulate an expression of interest form to everyone that's joined today. I think she just popped it there in the chat. So if you want to hear anything more about some of the papers or other materials that we hope to publish, then do get in touch. Or if you would just like to find out more about this project or about alcohol assertive outreach treatment in general, we're really keen to hear from you. Before we close down, is there anything you would like to add, Colin, in terms of next steps, as the person who's been here from the get-go?
I'm still here, and we're still going. So yeah, I mean, we're certainly in London and Hull and Newcastle. You know, we're going to continue to work on this area and areas related to this. The ARC South London has a work stream on assertive outreach. In Hull, you've got the new Centre for Addiction and Mental Health Research, which is also interested in this area. And in Newcastle, Amy, you can say what you're doing on it. But I think the general point is that, you know, we're still actively interested in this, and if people want to follow us or come with us on the journey, then we're more than happy to have you.
Very much so. So yeah, thank you everybody. Been a fantastic attendance and great kind of interaction from the audience. Thank you to all our speakers. Some really fantastic presentations there. I guess particularly thanks to our service users. I know it can be a scary thing to present on something like this, so really appreciate your involvement. But yes, keep in touch, use the expression of interest form if you want to hear more, and watch this space. Thank you.